Greetings, I'm Dr. Arthur C. Fleischer, Professor of Radiology and OBGYN, Chief of Diagnostic Sonography at Vanderbilt University Medical Center in Nashville, Tennessee. I will be presenting a talk on the concepts concerning the early detection of ovarian cancer with ultrasound and emphasize the new developments in color Doppler and in 3D, and finally with contrasted sonography. I hope you find this to be helpful. This presentation will cover the recent improvements in the sonographic detection of ovarian cancer. I want to give a tribute to Dr. Barry Goldberg, who has helped guide some of this research and certainly has helped me in my quest to develop new techniques in ultrasound. This is a picture of my sabbatical at Dr. Goldberg's. We imbibed, ate, drank ultrasound, and I again am indebted to him and his staff for giving me some of the ideas that 20 years later I am going to present during this talk. Basically, this talk is going to cover concepts concerning improved sonographic detection of ovarian cancer using morphology, using color Doppler sonography, using 3D, and also the new development of using contrast ultrasound in finding differences between benign and malignant ovarian masses. Microbubbles can be used off-label for general purposes in this country, but is not FDA approved at this point in time. We hope this will be changed in the very near future and have microbubble technology available for general applications. I am an unpaid consultant to Philips, and I am the recipient of an NIH grant concerning contrasted sonography. Basically, I'd like to cover some of the principles concerning color Doppler and amplitude or power color Doppler, and discuss the role of these technologies in depiction of tumor neoangiogenesis, and of course apply this to differentiating benign from malignant ovarian lesions. As we know, color Doppler allows us to understand the physiology concerning blood flow to the ovary and other structures, and it is hoped that it improves the differential diagnosis of ovarian masses over that based on morphology. Morphology meaning assessment of tumor wall, tumor papillary excrescence. Those are morphologic features. Now, in any new technology, it seems that there's a early part where it's great, 95% accurate, etc. And then there's an era of what I call inappropriate enthusiasm, where it's used for everything, and it's then an area of time of skepticism where we can understand it has some limitations, and then finally in reality it finds what its particular niche is in the clinical world. And I would say color Doppler has passed through these stages and is now a very useful technique in differentiating benign from malignant masses, and as well as making the diagnosis of torsion, which I will not cover in this presentation. Now, color Doppler depends highly on the angle at which we examine the vessel, and I would say not only does the amplitude of flow in the vessel count in its depiction, but the angle at which it's interrogated has a very important role in its depiction. And rather than quantifying the relative impedance values, the RI, which is resistive index, which is systolic minus diastolic over systolic, or the pulsatility index, which is systolic minus diastolic over the mean, we really can differentiate high from low resistance and also detect when there's reverse flow, which is a very high impedance to forward flow. Now, these flows depend on several factors intrinsic to the tissue that we're looking at. It depends on the downstream resistance, the vascular tone. Is the vessel constricted or is it dilated? And finally, interstitial pressure has a very important role as to what we see with color Doppler. A lot of tumors have very high interstitial pressure, and that affects the flow to the center of the lesion. And it also parenthetically affects whether or not chemotherapy can get into the interstitial portion of the tumor. Now, it was theorized that if we look at the various vessels, the one on the bottom is a tumor vessel that lacks a muscular media, that there is increased diastolic flow in these tumor vessels as compared to the vessel on the top, which has a muscular media which constricts a blood flow, and the differences in the waveform are significant. Now, the vessel in the middle is a vasodilated normal vessel, which can have a very similar appearance to either normal or neoplastic vessels. Another way of analyzing the color Doppler signal is by looking at the area under the curve, which is a reflection of the red blood cells that are coming into the field of view. And with using power Doppler, we can get even smaller vessels and their flow. And this is to differentiate the frequency-based color Doppler, which is very good but not as sensitive as color Doppler, as amplitude color Doppler. Now, as Fleming Frostberg showed many years ago, that amplitude or power Doppler has advantages and disadvantages. It improves our sensitivity, but it is susceptible to tissue motion artifacts, and there is no aliasing with amplitude Doppler, but there's no direction or velocity information. And there's limited temporal resolution, and this is going to play into when we talk about tumors and depiction of small capillaries, that the Doppler technique is in fact limited relative to contrast where you're looking at small capillary flow. Now, here we have a side-by-side comparison of frequency-based imaging and power Doppler imaging. And as you can see in this image, we have a multiloculated tumor and we have a few color Doppler signals. But with power Doppler, we can depict the vessels in the wall of this hemorrhagic ovarian cyst. This is another patient who's has a solid mass, and we can see that there are no central vessels, indicating that it was most likely a benign lesion versus a tumor which would have central flow. And we can see this on the power Doppler. We can see vessels only along the periphery. Now, basically, with that lesion, we depicted the larger vessels we could see on the vessel staining compared to the H&E staining. We could see pretty much what we were looking at with the power Doppler signal. This is a 3D representation of a normal ovary, and we can see that there are branching points and very orderly branching of the small arterioles inside the ovary, as shown histologically on the right, that have a muscular media. Now compare that to what Dr. Schonenfeld showed many years ago in a tumor. There's arteriovenous shunts, there's a tangle of vessels, as we can see here, and these vessels lack a muscular media, as shown histologically here. So one would think that their Doppler signals, and as we can see with contrast, that their entire flow pattern is different. Now, neoangiogenesis is a very important process in normal tissues, in corpora lutea, in placenta, in wound healing, for example, but these are regulated. After they're done, they're ended. Tumor blood flow is not regulated and continues to progress. Now, if we compare the very small tumor, this happens to be a breast tumor, a few millimeters, we can see the very abnormal vessels that occur very early in tumor development. And Dr. Folkman, of course, theorized, and correctly so, that for a small tumor to progress from 2 or 3 millimeters to several centimeters, it has to incite this abnormal vascularity. And in fact, inside the tumor, there's areas of abnormal interstitial pressure and areas of focal ischemia. We can see this on the slide, that as tumors grow, they have an increased interstitial pressure, which affects the vascularity in the tumor. So in the same tumor, we may be seeing different phases of vascularity. Now, color Doppler, I think, is helpful in looking at vessel density and arrangement in morphologically suspicious areas, and less important are the actual impedance and velocities. And with 3D, we can depict the vessel density, which I'll refer to later in the talk, and quantify this very important parameter. So what color Doppler is very good at is telling us what the physiology is involved with the normal ovary and ovaries that contain masses. And of course, where there's no follicular development, the vessels are very tightly coiled, and the impedance value is very high, as opposed to areas where there's a vascular arcade in a corpus luteum, where there's increased diastolic flow. We can see this visually here in this mature follicle, where there's vascularity around the periphery and a hypovascular space, which is an area where ovulation is going to occur. After ovulation occurs, there's formation of a corpus luteum. And again, as I mentioned, there's low impedance flow resulting from the corpus luteum, and the wall of the corpus luteum, the vessels, give a very low impedance value. And with power Doppler, we're beginning to see the branches, the small branches, from the wall in a corpus luteum, as shown here. And anatomically shown here is these very tiny vessels in the wall of a corpus luteum. Now, how to quantitate these vessels has been a subject of interest in several different studies. And basically, it's been shown that there is no magic value of RI or PI to determine if something is benign or malignant. And our study and others have shown that if we look at an ROC curve, receiver operating curve, our data shows that approximately a PI of 1.0 shows areas of about 80% accuracy. We can look at other parameters, whether the vessels are central or peripheral, and of course tumors have a more common central distribution of vessels. The systolic velocities are difficult to determine since we can't see the vessels in their entirety, and it's very hard to see exactly what the angle is. The impedance values are helpful, and the notch is really not. And when we put all these together, we come up with ROC values, but it gets very complicated, and we really need something a little bit more simple in describing benign versus malignant color Doppler features. We must remember that morphology is important. Morphology or shape is important. There's a big difference between these two individuals, and it's based on their morphology. Now, when we look at benign versus malignant, we know that smooth-walled structures are probably benign. Papillary excrescence, muronodules, and irregular solid masses are most likely malignant. And when we add color Doppler to that, the more regularly spaced vessels are more commonly benign, impedance high in benign lesions, and velocities are typically lower. And of course, changes in size is important. We should make sure that the mass indeed is still present after 1 or 2 cycles and not a physiologic mass. And finally, we need to know whether or not there's ascites, liver masses, or lymphadenopathy. So I want to show, rather than going over these specific guidelines, and they are guidelines, they're not certainly written in stone anywhere, some examples of what I've seen with color Doppler and ovarian masses. This was one of the first cancers we found. This is about a 2 by 3 centimeter ovary with an irregular solid area. Based on morphology, of course, one would be concerned about this lesion. And we could see that it extended into the fallopian tube on the left here. And here's the operative specimen with the tube clamped by the hemostat. And in low power microscopy, you can see that these are all very abnormal vessels surrounding the epithelial ovarian cancer. This is another patient that was being followed for follicular monitoring. There are 2 cysts, 2 follicles here, and in this area of the ovary there's a solid irregular papillary excrescence with a big blood vessel that has low impedance. And this was an ovarian, a stage 1 ovarian cancer, and this is the low power showing the abnormal proliferation of epithelial cells shown in purple in this ovarian cancer. Now, morphologically, this lesion has some suspicious characteristics. There's irregular wall thickening, there's an area of focal calcification, and in the wall itself we can see abnormal blood flow. This blood flow shows probably from vessels such as this that have no muscular media. Now, what was more concerning to me was the cluster of vessels right here surrounding the lesion, and these are associated with arterioles that are infiltrative in the fallopian tube in this ovarian cancer. This is a patient that presented for uterine bleeding, and we can see that there's a big solid mass with low impedance flow, and this is typical of a clear cell carcinoma. This patient has a cystic area in this ovary as well as this papillary excrescence. Now, most of the time papillary excrescences are associated with malignancy or borderline tumors, and we can see blood vessels in the papillary excrescence, which histologically it conforms to this on low power and on high power as areas of vascular infiltration by this papillary cancer. Now, we can differentiate cancers from benign lesions by showing that the lesion does not have any significant central blood flow, such as in this corpus luteum and such as in this hemorrhagic cyst that we can see has some fine linear interfaces inside the hemorrhagic mass, and this is characteristic of hemorrhage. And we can also differentiate tumors from non-tumors. This is a peritoneal cyst by showing no vascularity around the lesion. Now, our data from the mid-90s showed that we could be very accurate in excluding cancer. We had a 98% negative predictive value. But in any disease with low prevalence, a predictive value will be relatively high. We had a 83% positive predictive value in finding ovarian cancers, and the cancers that we did find were stage 1 or stage 2. Now, I must admit that these lesions do show significant variation in different studies, and some studies which included pre- and postmenopausal women showed various statistics. If one uses mostly postmenopausal women, the data, as you can see in the study on the right, shows much better specificity and improved positive predictive value. So is color Doppler clinically useful? The answer, of course, I think it is very useful, and it's useful as an adjunct to abnormal morphology. And we really feel that what we're looking for are clusters of vessels in morphologically suspicious areas. Now, the advantage of 3D allows us to see the vessel density and their relative branching pattern, as well as their vascular caliper. And so 3D is in fact helpful in looking at some of these tumor vessels, and I've shown you already that with tumors there's a cluster of vessels. The vessels have very abnormal branching patterns. And so this is one of our first images showing 3D in a tumor, in an ovarian tumor here, and adjacent to a patient with a cyst that has very few vessels surrounding it. So this is the niche type 3D determination, and we can see again the difference between tumors and the vessels in a cyst. With 3D we can see the papillary excrescence, and we can see sometimes the vessels inside the papillary excrescence. And here's a patient that has a solid area in this cystic lesion with a large feeding vessel. And this is at various degrees of rotation. Now I hope to show you this on 3D and distinguish it from a benign endometrioma. Now this is a 3D with vessels, as you can see here, that are very small. They don't course to the center, but very evenly spaced. Again, as you can see here, this is a benign lesion of the ovary and endometrioma. This, on the other hand, has a large feeding vessel going to the center of a solid area, which represented an ovarian tumor. And we can be very specific in differentiating the two. This is a 3D showing a volume of a metastatic lesion to the ovary, and you can see that there are large vessels that we'll see on the multiplanar image that course toward the center of the lesion. And this is apparent here as showing you all these large feeding vessels into the center of this metastatic ovarian lesion. So what we have here are multiplanar images of an ovary with central vascularity. And here are the vessels inside of the ovarian lesion showing abnormal branching patterns. So here are the vessels inside of the metastatic lesion. This is a lesion that has large central vessels, and as you can see, it's a tubo-ovarian abscess, but it points out how we can use 3D to monitor where a needle would pass if an interventional procedure is done in this patient. Here's the large ovarian mass with the central vessels feeding the walls of several small locules. And by sculpting and doing so-called electronic bloodless surgery, we can see inside the lesion. So we took the top off and are now looking down into the lesion. We can see the locules that are present inside the lesion, and these would contain perhaps a few cc's of pus, but the needle would have to traverse the large vessels to get to them, and therefore was not a very good idea to try to aspirate and get the very small amounts of pus inside of this ovarian lesion. So now we'll go back to where we were and put the tissue back bloodlessly and get out of the tubo-ovarian abscess that I've shown you. So with 3D we can do multiplanar imaging, and we can see these central vessels inside of ovarian malignancies. And this is a grayscale image now using 3D showing the abnormal branching patterns of the tumor neovascularity. Now I'd like to spend some time discussing angiogenesis and the depiction of angiogenesis with ultrasound. As I mentioned, the tumors incite a vasculature off the host vasculature using what's called vasogenic endothelial growth factor. And this produces very abnormal vessels that in fact have areas of ischemia inside of the tumor. And you can see this area of ischemia can be very large and plays a very important role into what we see with color Doppler. Now it became clear that with color Doppler we were in fact not seeing the capillaries that are integral in the tumor angiogenesis process. In order for us to get a Doppler signal, a lot of these small capillaries would have to be flowing at the same time, 100 or more, to give a Doppler signal. So it was hoped that with the microbubbles we can in fact see the small vessels and come to a better appreciation of perfusion as defined as blood flow over time in a particular volume. Now here's an animation showing what I'm talking about. We would grab a small capillary and we would image the microbubbles shown in blue through the blood flow inside of a tumor. So we were interested in this, in developing this technology, and basically we did many years of mice work with implanted tumors, and of course the microbubbles, as you can see here, are very small particles. They can pass through even the smallest of capillaries. And this is a picture of a microbubble. When increasing the mechanical index, the microbubble can be destroyed. This has a lot of potential in that if we destroy the microbubbles and then watch as they reperfuse, we can really come up with an idea of how the vascular bed how vascular these beds are. Now this is a video showing a 1 centimeter implanted tumor, and by flashing we could see the microbubbles, as you can see here in white, in the capillaries. inside of the tumor. Now, if we varied our flashing sequence, you can see in this tumor, we could destroy the microbubbles and watch as they come in. Or, as in this case, we do continuous visualization of the flow within the capillaries as the microbubbles perfuse this necrotic tumor. We can quantitate this activity in our time activity curve, where we can see the time to peak, the peak value, and the washout phase, and the area under the curve reflects the overall vascular volume. And this is shown in this image with the tumor and the time activity curve. We can also do a maximum intensity projection image and get an idea of what the vessel branching patterns are. And this has been termed the microvascular imaging. Now, tumors have approximately 5% of their total is made up of vessels, with, as you can see, 35% interstitium, about 60% of tumor cells. And this is a beautiful electron micrograph of the vascularity in normal tissues, with an orderly branching of arteries to arterioles to capillaries to venules, etc. Now look at the tumor. Tumor has a very abnormal vascularity, vessels that are big and small, and the transit time to get through something like this would be much greater. And that's what the microbubble technology is telling us. This is an intravital picture of tumor perfusion, showing some of the RBCs inside of the rat mesentery, and the arteries next to the veins, as you can see there. But these are, this is the level that we're imaging with the microbubbles. So what we're doing is we're looking at tumor angiogenesis. In the angiogenesis of tumors, there's a destruction of the basement membrane by metalloproteinases, followed by a fibroblast extravasation through these gap junctions, and they set up small abnormal vessels. And as you can see, whether or not the microbubble passes in to the tissue or not is related significantly to the interstitial pressure. This has implications as to not only how we image them, but how the chemotherapeutic agents get into the tissue and fight the cancer. Now, there are many applications of microbubbles, including the therapeutic potential for targeting the microbubble to a certain receptor, to having drug encapsulated in a microbubble, improving gene transfection, for example. Now, getting back to contrast in the ovary, there have been several studies. The first study was from Finland, where they used Doppler, and Doppler has the problem of decreased temporal resolution and blooming, but they did find a difference in uptake time in tumors versus non-tumors, and this is a follow-up of their study showing that tumors had overall increased intensity and longer dwell time. This is a study from France which confirmed that. Now, our recently published study first looked at tumor morphology and then went into looking at the vascular areas inside of the lesion. After we determined where vascular regions were inside the tumor, DEFINITY was used in an IV setup, 1 microgram per kilogram, followed by a 10 cc solution of saline. The images were stored on an offline system using QLab, and the following parameters were quantitated: the wash-in time, the peak enhancement, the washout, and the area under the curve, which corresponds to the vascular volume. Now here we have an image of a cystic mass. This is the fundamental image, the 2 by 3 centimeter lesion. Here's the contrasted image. This is the microvascular or maximum intensity projection image. And as you can see, with the contrast flowing in, we saw no abnormal areas in the wall of the lesion, and we could determine that this was most likely a benign lesion. Now, here's the time activity curve when we look at this area of interest, and we can see that there's relatively sharp upstroke, but relatively little as far as peak intensity. And this is the 3D of this lesion showing the vessels and their distribution. Now contrast this to this lesion. This is a cystic lesion with a very irregular border, and we can see the contrast coming into this lesion, but as soon as the contrast comes in, it leaves. So this is a relatively fast transit time. As you can see, it's decreasing in intensity right now. And when we look at the time activity curve, we can see that this lesion has, as we stated before, a very quick uptake and very short dwell time. As you can see now, pretty much the lesion shows very little of the contrast. And here's the time activity curve showing that high, relatively quick uptake and short dwell time. Now contrast that to this lesion, about a 2 by 3 centimeter ovary with a 1 centimeter cystic area. Now watch in this cancer how the contrast comes in and is very intense over a long period of time. As you can see here, the peak intensity is at 27 decibels, which is about 4 times higher than the others, and there's a very long dwell time, and this was an adenocarcinoma. This is the ovary and the other side, and you can see that it's enlarged, but note how there's marked increased vascularity in this ovary. Again, this is a patient with bilateral stage 2 ovarian cancer. And again, what we see is high peak, long dwell time. And this is the lesion itself. Here's the right ovary with a little cystic area in it, and this is the left ovary. Now, when we looked at the actual numbers, the time to peak was not statistically different in benign versus malignant. But when we look at the overall peak enhancement, there's about a 2 to 3-fold difference in benign versus malignant. And certainly the washout time is about three different, and the area under the curve is about 4-fold different in these different parameters. Now, so what we're saying is that we can look at the microvascularity, namely the capillaries, and make a differentiation between benign versus malignant. And the question is, can we do this looking at the macrovascularity? And we know for a long time that we can see in malignant lesions many more color Doppler signals. So in trying to quantitate this, we can come up with a vascularity index, which is percent of pixels or voxels in 3D with color over the total, or flow index, which is power-weighted pixel density, which relates to the intensity of the signal, or the vascularity flow index. And we can look at fractal dimensions and give an idea of vessel branching and caliper. We found in our initial work a significant difference in benign versus malignant in the vascularity index. In the power-weighted index, we also saw a very significant difference. Now, can we do this in 3D? And we're hoping that our data will show that with 3D we can do this in an even better fashion, because we have more representation of the tumor vessels. As you can see diagrammatically here, we can see more of the vessels using 3D. And in fact, if we magnify, we can see areas of microaneurysms, we can see areas of stenosis and abnormal branching patterns and venous lakes consistent with tumors. And this shows us an example of abnormal branching patterns in an ovarian malignancy, abnormal branches, as you can see in this papillary cancer, and many features of the abnormal vascularity, as you can see here, and you can see on this 3D video clip of tumor vascularity with vessels that go from dilated to stenosed to dilated, a very abnormal pattern and a very characteristic pattern of tumor neovascularity. So in summary, I believe that the improved resolution with 3D and with contrast has some significant advantages over morphology in making the diagnosis of ovarian cancer. We can look at, of course, papillary excrescences, irregular or focally thickened wall, and presence of ascites as the morphology of ovarian cancer. But now with color Doppler, we can look at increased density of the vessels, abnormal vessel morphology, branching, and with contrast, we can see abnormal washout times and greater vascular volume in tumors. And I'd like to thank my group at Vanderbilt for their team effort in working on this topic, and hope that you have success in finding patients with early ovarian cancer. Thank you.